physical session, I starts with the quiz, but because this is a virtual session, can any volunteer can share why I have highlighted H and A in HIV and AIDS? What is the significance of H, and these are the few common terminologies we will use in my presentation. So any volunteer, I just want to share what for HIV is so important. This virus is a human virus, so it will not be, it is a retrovirus, and it has two types, HIV1, HIV2, but both are in human. So this virus will not survive outside the human body in the environment or on the surfaces. So this is very important to understand. And second thing is, this virus is always acquired immunodeficiency syndrome. So it is not like flu, it's not like COVID, it's not like TB, somebody will sneeze or cough and you will get it. It is always some activity, some exposure which results in HIV and AIDS. So two basic terms, it's a human virus, and other thing it's always acquired. So PLHIV means people living with HIV/AIDS. The window period means when somebody is exposed to HIV, but antibody titer is not enough. So he will be HIV negative, but in terms of lab, but he will able to spread the disease because we measure antibody titers. PEP's post-exposure prophylaxis. We will talk about in detail when somebody gets a prick in a hospital of a drug addict of suspected HIV patients, what is post-exposure prophylaxis. Then there is pre-exposure prophylaxis. Like if somebody is a discordant couple, husband or wife, one of the couple spouses HIV positive and they want to conceive, so they will give the other partner who is HIV negative PrEP, pre-exposure. Then there is PMTCT, means prevention of mother to child transmission. So we have achieved that and we are working on the eradication. Next is VCT. So the HIV test has a lot of challenges. One of these, you need a consent for HIV testing. Second, it should be always confidential because he or she may be negative or positive. Then it must be late with a package of counseling, pre-test counseling and post-test counseling, because if somebody has exposed to a HIV but he is negative, he may be in the window period. Or if somebody is positive, then you need to tell him or her about his status of medical status, job, and his what he or she may not donate blood. So this HIV test, 3-4 things. One, it should be always voluntary with the consent, and the result should be confidential, and it should be associated with counseling. Next is EID. This is early infant diagnosis. Because maternal antibodies passed in newborns, and these are present in the till 6 weeks. So in first 6 weeks, every child has false result. So we wait for a PCR after 6 weeks. I've already touched the word key population. We will discuss them, but there are 4 key populations: IV drug users, transgenders, male and female sex workers. Then is VP is a vulnerable population. Those who are not key population, their risk is much higher than the general population, like GP, like truckers, like minors, like prisoners, like migrants and deportees. And then what is the link between Hep B, Hep C and HIV? And there's a term is called mainstreaming. What is the mainstreaming in HIV? I hope I'm not very fast. मुझे आपकी राय चाहिए. आई होप मैं बहुत तेज नहीं जा रहा.
No, sir, you are going.
Right. So the issue is that normal perception in Pakistan is that we have a high infant mortality, high maternal mortality, lot of diarrhea and ARIs, and we have our high burden. We have about 500,000 new cases of TB every year. We have a frequent epidemics of dengue. Every summer we have dengue and then malaria. And Pakistan is among two countries who have polio. We are the top burden case of Hep C. So HIV is not a problem. This is a common perception, not among doctors, paramedics, students, but policymakers, politicians, secretaries, and health ministers, that HIV is not. So we are in a state of denial. And the second perception is that it is a donor agenda. It is a Western agenda. Although we need to look into that, Europe and America have controlled it significantly, whereas all the developing countries like Pakistan, India, and Africa are still struggling with HIV. And the other thing is the challenge in HIV is that we cannot spread the message of awareness easily uh, using print electronic media because it is an STI and there's a lot of taboos. So we don't have much space to talk about HIV uh, openly in electronic media. And the other perception is there is no HIV in Pakistan. I was doing uh, a quality audit of a blood bank in a teaching hospital, and the technician was doing screening for Hep B and Hep C, but only writing HIV. He was not doing HIV and asked why. He said the kit is there because there is no AIDS in Pakistan. And this was a teaching hospital. So he was just writing no HIV, HIV non-reactive, but without testing. And and another issue is that we think that because of our Mashriqi Tehzeeb, Eastern values, Islamic country, we cannot have HIV in our country. So, so these are the perception of the public. I always start my presentation by showing this, and I want to sensitize everyone that this portion you are seeing this above the water is iceberg, huge HIV in the population. Why? Because Pakistan is number one in Hep C. About 6 to 7% Pakistanis have Hep C. Number one in the world in terms of disease burden, and one of the highest country with Hep B. So all those factors which leads to HIV are similar to Hep B and Hep C. So why HIV is less? Because of stigma. So we'll talk. So what you are looking at the HIV. So you are looking at the part of iceberg above the water which is visible, but actually it is 20 times bigger than that. So globally, HIV is still a major public health issue, and since start, it's claimed 42.3 million. ये तकरीबन 4.5 करोड़ people. It's a huge public health issue. Still valid. If you This is the latest stats available by UNAIDS that around currently we have 40 million, around 4 crore people are living in HIV, and annually 13 lakh, 1.3 million, and 6.5 million are death every year. So 13 lakh which is 6.5 lakh की deaths हैं, and people living with HIV are around 4 crore. If you see the global picture, the total out of 39, 40 million, more than half is in this sub-Saharan Africa. So this is the most high burden. Just look at it. The North America, 2.3 million, Latin America, 2.3 million, Eastern Europe, 2.1, 2 million, 2 million, 2 million. But the highest burden is here, and then Western Africa, 5.1. So we need to understand it's still the disease of developing backward countries. But after this bad news, a good news. Since 2010, in last half 1.5 decade, we have reduction in new infections of around 40% reduction in new infections. Why? Because of have a very good antivirals. Antiviral drugs are stopping the transmission of new infections. Similarly, the half of the deaths since in last decade between 2010 2020, 50% reduction in deaths of HIV, again because of very good medicines. You can see this. This is 1990, and this we are currently here, but the epidemics went to the peak in 1995, 96, and then the medicine arrives. And the good medicine, actually, which played a pivotal role, they arrived here. And you can see the availability of good drugs have just stopped the new infections. It's almost half now. Similarly, you can see again, this is last 2 decades, from 2000 to currently, you can see that there is a reduction in new infections. And similarly, age-related deaths since 2000 almost, the death is gradually, drastically come down to the baseline level because again of very good ARVs. They have stopped the transmission of disease. They have stopped the conversion of HIV into AIDS. So another success story, Sub-Saharan Africa has reduced 70% reduction in new infections since 1993, 70%. So these are good stories. But there's a bad news. We are living in Pakistan, and since last decade, when globally 40% reduction in new cases, 50% reduction in deaths, we have 84% increase. So there is something wrong in Pakistan. And I will discuss later why. Please park in your questions. So उसी वक्त में जिस वक्त में दुनिया भर में 40% के करीब रिडक्शन थी, उसी वक्त में in the same period 2010 we have 84% increase. ये पाकिस्तान की प्रोजेक्शन आप देखिए कि तकरीबन सिंस 20 यहां से सॉरी 2000 this is a modeling and we are here actually in 2025 it's around 350,000. These are estimated population, these are not actual. So Pakistan is following a typical epidemic Asian model where it starts in IDUs and then IDU transmit to their wives and into general population. A typical Asian epidemic model, epidemic infectious general population in 5 to 8 times risk for these IDUs, then MSM, and then they infect their spouses and bridging population, wives and children, and then infection in 5 to 10 years, it comes to general population. So Pakistan is has a very less opportunity to respond. We have out of 4 key populations, IDUs and transgenders, FSM, and MSM. Pakistan has 3 have epidemic of 5%, which is considered epidemic. So these are bridging population. Anybody who is IDU or migrant or transgender, they bring the infection to their home, to wife, and from mother to child. So these are not directly posing any risk, but because of they are called bridging population, they are exposed to the risk. So Pakistan still has the time to prevent spread of HIV as HIV is very low. Still, general population, it is low. So this is a global UNAIDS vision: 0 new infections, 0 discrimination, and 0 age-related death. This is the global vision for UNAIDS, and we have a global targets of 95, 95, 95 of people with total population. 95% know their status. So if there are 100 patients, 95 know their status. Out of those 95 are on ARVs, and out of them 95% have suppressed viral load. So if you look at it, this is the global targets. So this gray is the target, and blue is the achievement, and this is the gap. So you can see that in first 95 the gap is 68%, in second 95 the gap is 77%, in third 95 87%. But the key is here: unless we improve our testing, we cannot achieve the next 290s. So Pakistan currently, last estimate states that we have 3,030, 3,30,000 मरीज हमारे पास estimated हैं. When all ART center registered around, we have around this 76,000 and 53,000 are on ARV. So these are adherents. These are registered, but they start medicine, they leave, they start medicine, they lost to follow. So these 53,000 are adherent. So this is a snapshot of the last 5 surveys. First, second, third, fourth, and fifth. And if you just follow the blue line, IDUs, in 2005, the prevalence of HIV in, so we what we do, we we test the blood sample of these populations: IDUs, transgenders, male sex workers, female sex workers. So in 2005, the first round, it was 10.8%.
ऊपर आओ
And
हाँ
in 2007, it was 15.8%. And just you can see in within 2 years, it multiplies from 10 to 15%. And within 1 year, it increased from 15 to 20%. Within 3 years, it increased to 36%, huge. And in after 5 years, it was stable. It was 38%. So, so 5% is considered epidemic. So we have a constant epidemic in IDUs. Similarly, the other populations. So they are gradually increasing. Uh, Red line is transgender, 7.2%. Your yellow line is MSM, male sex workers, it's 5.6. So in last survey, 2016, it was only the FSW which were less than 5, but we have a new survey last year and we were waiting for the results. These are few high burden cities, and you can see that although the in Karachi, every second IDU is, I just want to, so these are high burden cities. You can see Karachi, uh, almost every second IDU is just, positive, every 10th MSM. Similarly, these are high burden cities. These are again high burden cities as per our treatment data. So we have a huge burden in Peshawar, in Quetta, in Karachi, Larkana, in Punjab, DG Khan, Faisalabad, Lahore, Sargodha, Gujarat, even Faisalabad also, and Islamabad. So these are the high burden pockets in the country. So we have all the four provinces, but predominantly 93% of burden is in Punjab and Sindh. So this is a very interesting slide where we are comparing national data with a high burden city. So in transgender, the national says it is 7.1% are positive, but Larkana it is around 3 times, 18.2. In MSM, national data is 5.4, but Karachi is double. So IDU's national data is 38%, but Kasur is more than 50%. So in FSW, the national data is 2.2, but it's 4 times in Sakkar. So the national data is average, but we have few high burden cities across Pakistan. So if you can see this gray color is IDUs, green FSW, this is transgenders, and this is male sex workers. You can see in first round, the picture was not so bad. And in 2016, it was very much bad. And we are waiting for the results for 2024. So HIV is increasing among the key populations. These all four are key populations. But what are the reasons among the general population? So we have talked about the risk of the key population. Anybody who is using repeatedly syringes, needle sharing, or unhealthy sexual behaviors in transgenders or male or female sex workers. But what about general population? What is happening in Tonsa? What is happening in Nishtar? We have a culture of injection and drip in our country. There is a study in KPK where 10 to 14 injections are used in 1 year, which is very high. So we have a huge burden of drug addiction. One is drug addiction and other is IV drug addiction. So we have a huge burden of drug addicts, and the phenomena is they share the needle. So blood transfusion, we have congenital anomalies, diseases, hereditary diseases like thalassemia, hemophilia, around more than 100,000 kids with thalassemia major who needs repeatedly blood transfusion. So we have annually 3 million blood bags transfused in the country, from around 700 blood banks and collection centers, mostly unregulated. Similarly, a lot of people are going outside, especially the GCC country where family is not allowed. So they come after 2 years to meet their families, and they are at risk. There is a lot of cross-border movement, Pakistan, Iran, Afghanistan. So viruses have no borders, and there are a lot of unhealthy sexual practices. We have red light areas. We have commercial sex workers. And in female, we have ear, nose piercing, tattooings. Lot of surgical and dental procedure are unsterilized. So even the doctors and quacks are not. It's quackery. Actually. Even doctors are they are not sterilizing their equipment. They are putting their patients at risk. So what are the three major factors in the Pakistan? One is the denial from the public, doctors, the policymakers, and everybody is in denial that HIV is not an issue. Other is the stigma. Every day, if you will see a patient in a ward, what will be your reaction that the patient is HIV positive? And the third thing is taboo. You cannot talk about the disease openly in the country because of our Eastern values, Islamic country, but it's the wire is under the carpet. So Pakistan, I've already explained, 30,000 is uh, the estimated population. And Pakistan is considered to be low prevalent country previously, but now in 2017, we have constant epidemic in all key population except FSW. We have 95 ART centers in Pakistan across in 4 provinces in GB, AJK, and we have also in predominantly in teaching hospitals and DHQ in Punjab, but we have private hospitals like Aga Khan, Shaukat Khanam, Ziauddin, Indus, in CMH Rawalpindi, where we have ART centers. These are famous outbreaks. So overall, the approach of the country is reactionary. So we have the first outbreak in Jalalpur Chatta. It was ID drug users, then in Ladkana dialysis, then Chennai 2017, that Kotamrana, Punjab, and then Ratotero, the famous in children, and then recently in November, Nishtar Medical College, and currently it is in Tonsa. So the people in the DG Khan, they knows what is the panic among the population. Uh, these are again the same timelines. This is the new cases we are getting. So in 2018, 7,700. In 19, around 10,000. In 2020, because of COVID, it dropped. But again, after 21, it's again back to 10,000, and now it is 12,000, and then 13,000 last year. So these are new cases. Every around 1,100 cases, new cases are coming to our treatment centers every month. Uh, Regarding AIDS, AIDS is still the world leading cause of premature death among age between 15 to 59, the most productive age. It's still half of all new infections globally occurs in youth, 15 to 24. This is the age where you go to college or university or to army or to factory. So, and UNAIDS report that globally still the AIDS is there, although the epidemic is reversed. But three countries in this region, Pakistan, Indonesia, and Philippines, are showing increase in HIV cases. And I have already shared the reason. I hope I'm not very fast. जी मुझे कमेंट चाहिए मैं बहुत तेज तो नहीं जा रहा हेलो अच्छा जी HIV एक तो ये दिस इज एन STI सेक्सुअली ट्रांसमिटेड डिजीज है and मरते मर गई दोनों kindly mute yourself so there is no cure like like diabetes and hypertension but it's fully preventable and if somebody is on antiretroviral drugs so the individual become undetectable so if somebody is undetectable he will never convert from HIV to AIDS so he will not be pushed into syndrome so HIV ARVs are very good. They prevent transmission from mother to child during pregnancy, during delivery, and similarly, they so who is on antiviral therapy is virally suppressed will not pass to their spouse. So it is so who are at more risk 25 to 35 9 age. This is the highest risk. I have already tell about the adolescent young population. So key population, partners of PHIV, STI patients, lost to follow clients. 95% of new infections are globally in key population. So this is important. The fire is more in the key population. And look at the risk. IV drug user is 35 times more higher risk of getting HIV. The transgender has 34 times. The female sex worker has 26 times. And the gay man, MSM, have 25 times higher risk. So these four are the key population. So if we need to minimize these risks. Uh, according to UNAIDS, HIV is, although the globally the disease is on decline, but the gay man is still 11% increase. Similarly, 3% increase among transgender people, since because their risky behavior is there. So this is the WHO slide showing the mode of transmission with percentage. So 31% is in IDUs through IV drug users. This 2% is mother to child transmission. This 5% is through male, and this 39% heterosexual, 5% through blood products, blood transfusion, and 18% is unknown. So there are three major areas in terms of transmission. One is it is STI, sexual, husband to wife, or so other is mother to child transmission, and third is through blood additive injections and drips. Kindly mute yourself. If you can see that these are the body secretions in blood, the viremia is high HIV virus in 1 ml, 18,000 viruses, in semen 11,000, then vaginal fluid 7,000, amniotic fluid 4,000, milk 1,000, and saliva in 1. So the highest is in the sexual transmission, either blood in semen, vagina, amniotic fluid, plus the blood. So you already know the mode of transmission: sexual contact, needle sharing, needle stick injuries, breastfeeding during pregnancy, and unclean, unsafe blood transfusion. These razors, toothbrush, this tattooing, acupuncture, these all. So prevention is, we need to ensure safe blood which is screened for Hep B, Hep C, HIV, malaria, and syphilis as per national WHO guidelines. So in terms of risk reduction among IV drug users, we have needle syringe exchange program, and we are starting a program of oral substitute therapy in Lahore and Karachi soon. So we need to encourage to avoid drugs, healthy lifestyle. We need to avoid unnecessary injection and drips. Just share an example that Neurobion is available in syrup form, in tablet form, but 99.9% sale is drip injection form. So we need to get rid of this. So use of auto-distributable new syringes in Pakistan, and we have to avoid risky lifestyles. We have to be very faithful to our spouse, encourage nikah, and we have to avoid extramarital relationships. This is key. Similarly, for women, girls, safe piercing of nose, ear, and tattooing. And for surgeries and procedures, we need to ensure that the instruments are properly sterilized. We need to adhere to standard universal precautions, and we need to have availability of post-exposure. If there is a prick, if there is exposure while doing some procedure, we need to show availability of post-exposure prophylaxis drugs. Similarly, mother to child transmission is 100% preventable if mother is on ARVs, and we need to avoid the mother feeding. So the myths. So HIV is not transmitted through shaking of the hand or hugging or drinking from the same glass or eating on the same plate or working in the same office using the mobile phones or washrooms. So I think it's all repeat. So it's not spread through sneezing, coughing, tears, and getting some HIV patient from a mosquito bite. So or living in the same place. So there are still a lot of myths other than this, that HIV person cannot marry. No, HIV, if a person is HIV positive, if he or she is taking ARVs, medicines, and after 90 days they are virally suppressed, they can marry. HIV cannot become a parent, reproduce. No, if a husband or a wife, anyone of them are HIV positive, we give a PrEP therapy pre-exposure to other discordant couple so that they can conceive and they can have a HIV negative baby. So HIV women can become pregnant. HIV patient nowadays can do any sort of job. It's the only medical jobs where there is a risk. Otherwise, they can perform all the jobs except if they're exposure to patients. So the myth is, can we get HIV by being around HIV positive people? No. False. HIV transmission of infected body fluids, materials, blood, semen, vaginal fluid, breast milk comes in direct contact with mucous membrane, mouth, vagina, anus, damaged tissues, or injected into bloodstream. So can we get HIV just by handling phlebotomy, examination, management, procedures, surgeries, deliveries? HIV positive individuals in your daily life? No, if universal precautions are practiced. You touch them. जी, I'm audible? जी, मुझे कोई feedback दे दें,
Yes,
मेरी
sir, you
आवाज आ
are.
रही है?
Yes,
I'm
sir.
not very fast. I'm not going very fast. जी, kind सबको भी फिर ना अब
Yes, sir, you are going a little
mute.
bit fast.
अच्छा, चल,
Everything else is.
चल, ठीक. Please give me a feedback. So, you are a medical student or you are going for a house officer, a house surgeon? So if there is a patient with bedside big board that patient is Hep B positive or Hep C positive, nothing will happen. But if the chart said that in red marker that patient is HIV positive, what is your reaction? So similarly, if you are sitting in the OPD and the patient disclosed that and you are examining his throat through a tongue depressor in your hand, he or she says, "Madam or sir, I am HIV positive." What is your reaction? Similarly, if you're in a lab and you're doing the phlebotomy or you are assisting a patient and you know the result is HIV positive, you're doing some procedure in OT or labor room, and then you find that patient is positive. Most of the people still in Pakistan, they panic because we don't read. And this is a dilemma that Hep B is very infective, very virulent. Hep C is moderate and HIV is not, but we behave other way. So this is a WHO slide. You can see this, that this is risk of transmission between Hep B, Hep C, HIV after blood and body fluid exposure. Right? Hepatitis B का exposure है, अगर prick हो जाए, between 18 to 30%, almost one third. Hep C का around 7%. HIV का 0.1, 0.3. सो ये एक 100 प्रिक्स में से चांसेस ये हैं कि 18 से 30 लोगों को हैप भी हो जाएगा, 7 लोगों को सी हो जाएगा, एक को भी HIV नहीं होगा, 1,000 के बाद 3 को होगा, 1,000 के बाद. सो द लिस्ट इज लीस्ट इन HIV, but we are more afraid of HIV because we don't read. And why the risk of transmission is increased when there is a hollow bore needle, we have needle stick injury if the injury is deep, if the viremia is high, or similarly if there is a visibly contaminated blood are reported. Average, this is 30 needle stick injury per 100 beds. So if you take the stats, one third of the beds, 30 out of 100 beds have needle stick injury. So the first of all, you need to get vaccinated from Hep B. You need to ensure before going to ward hospital that you are Hep B vaccinated. So I'm not going in details for Hep B and Hep C, but for HIV, it's prevention. So 7% in of the patients in developed country and 10% in developing countries, at least one hospital-acquired infection. Risk of hospital-acquired infection is 2 to 20 times higher in our countries, 20 times higher. So most of the healthcare hospital-acquired infections are preventable with effective IPC. So what are the IPC protocols to reduce the risk of HIV? Number one, unsafe injection practices. हमें injections को reduce करना है, डिस्करेज करना है इंजेक्शन को और ड्रिप्स को. और दूसरी बात है कि कोई भी नेवर ट्राई टू रीयूज syringes or needles. So it's similarly improper handling of sharps equipment, inadequate installation of medical equipment like endoscopies and bronchoscopies and all OT instruments, all delivery instruments, dental instruments. We need to have a strict sterilization protocols, and we need to follow them, and we need to document them. Similarly, standard transmission, we need to understand the mode of spread of each infection. Hand hygiene is very important. We need to ensure hand washing. we need to ensure you need to be in your that after looking after every patient. It's a bit challenging in Pakistan, especially in public sector hospitals, but it is your life first. If you are healthy and safe, you will ensure health to your patient. But if a doctor is sick, he cannot ensure. So first of all, it's your life, it's your health. So all standard precautions, personal protective PPEs, in COVID, we need to use gloves, masks, gowns, and all gears. So aseptic techniques, maintaining sterility during medical procedures, cleaning, disinfection, sterilization. We need to ensure proper medical equipment, environments with proper sterilized as per recommendations. So, in what is infection control? Infection standard precautions, immunization. Everyone must be vaccinated against B. At least have B. We have a vaccination available. Similarly, waste management. That the waste of the patient, especially for the HIV patient, cleaning and disinfecting services, usage of sharpeners and PPEs. So and the trainings and quality. So every should to be documented. So disease transmitted to healthcare workers during blood and body from through blood and body fluids. BBF is blood and body fluids. So Hep B, Hep C, HIV. So it is transmitted in clinical practice. And this is a comparison between Hep B, Hep C, and HIV. You can see on the left hand, HIV is preventable through vaccination, but it's most virulent, very small, like 10 to the power 10 to the power minus 8 ml, 0.000001 ml of Hep B can cause infection. But it to unvaccinated, fortunately, the HIV virus is very sharif. It cannot survive outside the human environment. So risk of transmission is low. But the mental stress is huge among healthcare providers. If you have a prick and you know the patient is HIV or unknown, so there is a huge mental torture. So I just want to. So highest risk is when there is a deep needle sticks injury and the large volume of blood is used in a hollow needle or exposure to high titer activation, high viremia. So you see, similarly, there is no risk if there is no exposure to large volume of blood and there is low viremia. These are just pictures to show you if these boxes is inappropriately used, overfilled, avoid recapping. So we need to avoid all these, use proper PPEs among all the staff, and avoid these scratches or abrasions from the medical waste. It is just a comparison global that annually we have 66,000 have been infections among healthcare providers, 16,000 infection from HCV globally, and 1,000 HIV. So still there is no match between 1,000 and 66,000. So, but people are more afraid of HIV. So you need to educate yourself. So we have 3 million needle stick injury annually among 35 million healthcare providers, and 90% are in poor countries. Infections acquired through occupational route are largely preventable through strict IPC policies. You need to implement infection prevention policies in your hospital, in your clinic, in your nursing home. And these are all good practices globally. Healthcare workers need to know their risk, how to protect themselves against blood and body fluids, risk of infection, what are the mode of transmissions, how to prevent the barriers. Similarly, trainings and use of PPEs and a lot of trainings are available online. So the spill management, HIV virus on surfaces they cannot survive, but it's always good to use, the standard precautions like disposable gowns, gloves. Whenever necessary, you can use double gloves and shoe cover. So and all such things. So if there is a prick and you don't know the status of a person, or if you know the status, if it's a drug addict, highly likely that he or she may be HIV positive. So post-exposure prophylaxis is offered within 28 days, within 72 hours for 28 days, and it prevents 100% of viral application. So, but the deadline is 72 hours. So anybody who has exposed, has hospital accident, any exposure, must report to HIV clinic within 72 hours. It's 100% preventable, but the time is important, 72 hours. And it's available round the clock on OPDs and ER in all our 95 ART centers. I will share the list. So possible exposure causes through shared needles, syringes, through sexual assault, workplace exposure, post. So it should be offered to all occupational and non-occupational exposures. The regime is uh, uh, DTG, we call it, for 28 days. So what we should we do? We should, the baseline parameters of healthcare providers, anybody who has got pricked must be checked for HIV status. So drug should be started and at least for 28 days. And if source is unknown, then you need to decide whether to give yes or no. But if the source is HIV negative, no drug is required. So similarly, if you have exposed, if you have pricked, do not squeeze, wash with soap water, cover with waterproofing, and check the viral marker of the patient and yourself, and then report to the department. I must say for HIV clinic. Similarly, for needle use, do not recap. Do not recap prior to disposable. Discard the sharp boxes when 3x4. Don't wait for to fill it 100%, and do not overfill. These are sign symptoms. When there is an exposure, there may be a flu-like symptoms, but normally these are not significant. But if a person represent with lymphadenopathy or repeated history of diarrhea or mouth ulcers or fatigue of unknown region, you must rule out HIV. Proper history of exposure is important. History of blood transfusion, history of surgery, history of trauma, history of sexual exposure, history of drug addiction. So what we are doing at the national and provincial level, free of cost provision of ARVs, which is medicines, lifelong are available, free of cost testing. Anybody wants to get test. Similarly, the high-tech institute like CD4 count and HIV PCR is available free of cost. We have 95 clinics I've already shared. We are linking these patients to the social health program, protection, basic income support programs, health service program. We provide them nutrition. And the government also oversight and support NGOs to work for the prevention activities. And we link all the positive clients from the prevention setups to the treatment. There is an NGO, Nai Zindagi, working for IDUs, and their intervention is they give 3 new syringes they collect the old syringe and they test every 6 months the IDUs, drug users, all the positive clients, their spouse are tested, they are offered prevention program, and all the positive clients are linked to the HIV clinic. And we have community-based organizations who work for transgender, FSW, MSM. They reach their hotspots, their datas, they give awareness, and they offer testing every 6 months and link the all positive to treatment. What are the investigations available in the country? So we have HIV rapid test. I will show you the algorithm. One is combo, and then Unigold and SG Bioline. HIV rapid self-test. We have CD4 count, which gives us the immune status. And then the early infant diagnosis is qualitative PCR available at PIMS and at Punjab Age Control Lab. And then we have a qualitative PCR, which is available at PIMS, and we are currently doing it through Aga Khan across Pakistan. So one of the challenges is the window period. We measure the antibody, and you can see this gray line. The antibody appears at around 22nd, 23rd day. So if the patient comes between exposure to this time, his result will be negative, although he will be positive later on. So anybody who has history of exposure, he must be explained to come after some time so that antibody titer can be raised. Because before this time, you cannot say he's positive or negative. So these are the rapid devices which we are used in the field. They're easy to handle, and they're an algorithm. The algorithm is that for every patient, we go for the first test, which is combo antibody test. And if it is negative, you report the patient is negative. So there is no, but if it is positive, we go for the second test, which is Unigold. And if it is negative, so we will advise the patient to come after 2 weeks. And if it is positive, we'll proceed for the third test, which is SD Byline. Anybody who is positive on three tests, first, second, and third, will be, third is confirmatory test. So we start antiviral medicines. So the innovation is now self-test, which are available both from blood and from the OraSure for oral mucosa, which are available online. This is CD4 machine. It's a small machine around our size of a mobile packing, and you can get the CD4 status for patient. Exact count are given, and this is our PCR machines across country. These are early infect diagnosis gene expert machine where do the qualitative PCR. So we have 95 ART centers. You can see it's very strong coverage in Punjab. Every DHQ has a HIV clinic, and I will share the list, and then Balochistan, and then AJK and GB. These are the list in Islamabad. We have PIMS in Polyclinic, and then CMH Pindi, in GB, PHQ Gilgit, in AJK AIMS Hospital. Then in KPK, it's available, the HIV clinics in Aptabad, Swabi, Bannu, Batkhela, Kohat, Mardan, HMC Peshawar, LRH Peshawar, DA Khan, Swat, Bajod, Miran Shah, and Parachanar. In Balochistan, it's available in Quetta, Loralai, Nasirabad, Turbat, and Hub. In Sindh, it is a really long list, but it's almost available in all DHQ's hospitals. But obviously, Ladkana and Karachi have more centers. In Punjab, it's available in all the THQ level, and now we have a new center at Tonsa also. The challenge is these HIV treatment is lifelong, so it is very expensive, and for a country like Pakistan. So treatment is expensive, but prevention is absolutely free. It's just a lifestyle. So the other challenge is that both the medicines and the diagnosis are not produced in Pakistan. So it is a challenge to maintain the inventory. International procurement always is difficult. And the challenge is low HIV testing because of huge stigma. It is a lifelong medicine, so the adherence is challenging. We have a huge loss to follow-up. We have stigma, denial, and funding issues. This is just a pipe showing where the leakage are. So the key populations, where the key population, then it's difficult to reach to them, and sometimes we reach to them to link to the testing services after testing to start with the treatment, and then after to start treatment to maintain their adherence and to maintain their viral suppression. So we have a lot of leakages in the HIV pipeline in the country. One of the way forward is to destigmatize it, because non-sexual modes like mother to child transmission, through needle stick injury, through blood safeties. In Pakistan, most of the outbreaks was because of drug IV or bad infection practices. So we need to destigmatize and make it humanize. And we are a resilient nation. We have done miracles in one very good successful response in COVID. We can do it. It's just a teamwork. And universal precautions. You need to observe these precautions for every disease, not for HIV, but for Hep B and Hep C. And let's say Hep B is more virulent. We need to develop customized IC material, which can cover both Hep B, Hep C, and HIV. And we need to mainstream it. So we have partners. If we have time, I want to add stigma. जी मानूर आप बताएं कि टाइम है स्टिग्मा की 3 स्लाइड्स हैं.
Yes, sir, we have time, please.
Sure. ये देखिए, ये there's a list from monkeypox to COVID to Nipah, chikungunya, dengue, SARS, Ebola, measles, avian flu, long list of emerging infections. But my question is, why there is stigma with HIV? ये मैं आपसे बाद में पूछता हूँ, आप लोग फिर सोचें कि what are your answers? Why? It is sexually transmitted disease. It's related to your character. So you cannot talk openly about HIV. So this term, double stigma, I use it because if you see a transgender on a signal, what is our response? We avoid them. Similarly, if you came across an IV drug user or a sex worker, what we avoid them. But if this IV drug user or transgender is HIV positive, I call them stigma of their key population status. They are IV drug users or these are transgenders, and stigma of HIV. So I called it a double stigma. Uh, if you have seen this Shoaib Mansoor movie Bol, which is a description of a transgender's life, uh, we need to understand there is huge stigma about HIV. I've already explained because of it's related to your character. If somebody has exposed to HIV through blood, unsafe blood, or drip or injection, but the society will treat him or her for bad character. So we need to develop our empathy for these populations. These are very marginalized population. So we always relate it कि उसने कुछ गलत किया होगा, and we don't know हम में से किसको HIV हो, we don't know, हमने टेस्ट कराया नहीं है. So we are always judgmental. दूसरे को हम ये जो अल्लाह की ड्यूटी है वो हमने ले ली है. So we need to be non-judgmental. We relate it to the bad character, and we label every HIV for a bad character. That's why people are not going for test. So stigma results in divorce, murder, suicide, termination of job, blame game, denial to health services. Every day I receive a call across the country that gynecology refuse cesarean or normal delivery, or hospital has refused endoscopy or dialysis, that patient is HIV positive. So I have shown you that it is much less virulent than Hep B, Hep C, but in society we have this huge stigma, and the problem is it is among doctors, which is extremely bad, which result in the limitation of accessing healthcare services to these patients. Somebody is bleeding, but nobody is stitching the patient because HIV positive. Mother needs a delivery in a labor room or needs cesarean, but she's deprived of the services because of her HIV status. You can see this, that people are sitting, in the family is sitting, and the HIV positive exclusion. You can see that exclusion. You can see this is a cartoon, but before COVID, labeled HIV positive, and you can see the mood and gloves and mask. You can see the mood. Patient is labeled as HIV positive. It is a transgender, and you can see the mood here, and you can see that how the nurse is wearing gloves with such a ihtimam. So we don't treat patients as humans. So these are few sources. This is our website where a lot of guidelines are available. This is our community-based APL-HIV's website. This is the Sehat Dose where you can get the self-test kits, and we are developing few apps more. This is a WHO website for regarding HIV. This is UNAIDS resource. This is APNA has run HIV course for 6 months. Recently, we have conducted the last session last Sunday. And this is the guidelines for infection prevention developed by NIH. This is the guideline. And these are the helpline. You can access this number 24/7, this number from 9 a.m. to 9 p.m. This is our number. And then there's an email ID also. So thank you very much. And the floor is open for questions. Thank you.
Sir, I have a question.
Please.
सर आपने कहा कि ना आपने ना साइंस एंड सिम्टम्स का एक पेज दिखाया था कि ना ये सिग्निफिकेंट नहीं होते, आपने कहा था ये अपेयर होते हैं लेकिन सिग्निफिकेंट नहीं होते. सर अगर एक बंदे को HIV इन्फेक्शन हो गया किसी भी वजह से और उसे कोई सिम्टम्स भी अपेयर नहीं हो रहे, तो वो कैसे चेक करेगा? मतलब उसे तो वायरस का पता नहीं चलेगा कि उसकी बॉडी में एंटर हो गया या नहीं होगा, वो इलाज कैसे करवाएगा?
जी, इसमें इसकी जो की है ना, वो है अवेयरनेस। हमें सबसे पहले तो डॉक्टर्स, मेडिकल स्टूडेंट, नर्सिंग्स को अवेयर करना है, जो मरीज को रिफ्यूज कर रहे हैं। जिस मरीज को जब एक्सपोजर होता है ना, तो ये अल्लाह मियाँ ने हमारे लाशों में रखा है कि जब भी हमें कोई भी काम ऐसा हो जाए जो गैर मामूली हो, वी गो टू डॉक्टर और वी गो फॉर टेस्ट। अगर हमारा कोविड के पेशेंट के साथ रब्ता हुआ है बस में या ट्रेन में या रूममेट, तो हम कोविड टेस्ट कराते थे। हमने अगर ब्लड लिया और हमारा ख्याल था ब्लड ठीक नहीं है, वी विल गो फॉर ऑल और टेस्ट। सो HIV की जो इनिशियली देर आर नो सिग्निफिकेंट सिस्टम है ना, एक छोटा सा फ्लू की तरह एक होगा, एंड वी हैव 8 to 10 years जब वो HIV से सिंड्रोम में जाएगा, एड्स में जाएगा। इसलिए द वेरी गुड वर्बल हिस्ट्री इज इंपॉर्टेंट, हिस्ट्री ऑफ ब्लड ट्रांसफ्यूजन, हिस्ट्री ऑफ रिपीटेड इंजेक्शन यूजेज, हिस्ट्री ऑफ एडिक्शन, हिस्ट्री ऑफ ओवरसीज जॉब, हिस्ट्री ऑफ कि प्रिजनर में गया है। जैसे आप, जब तक आपकी अच्छी हिस्ट्री नहीं होगी आप नहीं पढ़ सकेंगे, बिकॉज जब वो सिंड्रोम में जाएगा तो उस वक्त इट्स टू लेट। हमारे पास पेशेंट आते हैं विद CD4 काउंट 0 और 4 और 5, जो 1200 होनी चाहिए CD4 काउंट, और उसको 8 से 10 साल लगते हैं CD4 को कम होने में। लेकिन लोग बहुत लेट आते हैं, इसलिए कोई स्पेसिफिक सिम्टम नहीं है, आपको हिस्ट्री ही लेनी है। और जब भी कोई पेशेंट ऐसा है जिसको बार बार फंगल इन्फेक्शन हो रहा है, बार बार डायरिया हो रहा है, ठीक नहीं हो रहा, बार बार निमोनिया हो रहा है, बार बार स्किन इन्फेक्शन हो रहे हैं, बार बार लिम्फ एडिनोपैथी हो रही है, तो फिर हमें सोचना चाहिए कि इसको HIV है या कोई और। वी नीड टू इन्वेस्टिगेट द क्लाइंट और पेशेंट कि इसको ये क्यों हो रहा है, वाई डायरिया, इसको हर दूसरे हफ्ते डायरिया हो रहा है, या वाई फंगल इन्फेक्शन। जी।
और सर आपने कहा था कि ना अगर मतलब किसी बंदे को HIV हो गया तो वो फौरन से टेस्ट ना करवाए बिकॉज फॉल्स नेगेटिव आएगा, एंटीबॉडी टाइटर्स को रेज होने में टाइम लगता है। ठीक है, तो इसके बारे में बता दें, मुझे इसकी थोड़ी सी समझ
जी
नहीं
मैंने
आई।
देखिए जी मैंने सर्च किया कि मैंने अर्ज किया था कि HIV की टेस्टिंग को हमने हमेशा लिंक किया काउंसलिंग के साथ। तो और टेस्ट काउंसलिंग दो तरह की है, एक प्री टेस्ट काउंसलिंग, एक पोस्ट टेस्ट काउंसलिंग। प्री टेस्ट काउंसलिंग में जो काउंसलर है वो पूछता है कि आपका एक्सपोजर कब हुआ है, आपको ब्लड लगा है, सिरिंज लगी है, सेक्सुअल एक्सपोजर हुआ है, क्या हुआ है। तो चूंकि एंटीबॉडी बनने में तकरीबन तकरीबन 20-21 दिन लगते हैं, उससे पहले अगर हिस्ट्री, स्ट्रॉन्ग हिस्ट्री है एक्सपोजर की, तो उसको हम अगर टेस्ट नेगेटिव भी आ गया, उसको हम ये बताएंगे कि आपका टेस्ट नेगेटिव है, लेकिन चूंकि आपकी हिस्ट्री एक्सपोजर है, आप 2 हफ्ते बाद दोबारा तशरीफ लाएं। तो पेशेंट को ये बताना जरूरी है कि आपके नेगेटिव टेस्ट का मतलब ये नहीं है इस वक्त कि आप नेगेटिव हैं। और मरीज जिसका एक्सपोजर होता है, बिलीव मी, वो मरीज खुद डरा हुआ होता है, उसको सिर्फ ये बताना जरूरी होता है कि आपने टेस्ट के लिए दोबारा कब आना है। तो जैसे जैसे हमारी टेस्टिंग बढ़ेगी, बिकॉज ट्रीटमेंट खुद एक बहुत बड़ा प्रिवेंशन है। जैसे ही कोई शख्स जो है HIV की ट्रीटमेंट स्टार्ट करता है, विद इन 90 डेज वो वायरली सप्रेस हो जाता है। फिर वो टाइम बॉम्ब नहीं है, फिर वो स्प्रेड नहीं करेगा, फिर हस्बैंड वाइफ ट्रांसमिशन नहीं होगी, मदर टू चाइल्ड ट्रांसमिशन नहीं होगी, और लाइफ एक्सपेक्टेंसी अब बिल्कुल नॉर्मल है। हम जब डॉक्टर्स की ट्रेनिंग कराते हैं तो वी starts with if Allah Mia give us choice to choose between diabetes, hypertension and HIV, we will go for HIV because very good medicines। जैसे आपने बहुत अच्छा डायबिटिक कंट्रोल किया, फिर भी रेटिनोपैथी हो जाएगी, नेफ्रोपैथी हो जाएगी। तो HIV के अंदर जैसे ही अर्ली डायग्नोसिस के बाद आपने ट्रीटमेंट स्टार्ट कर ली ARVs की, तो 90 डेज के बाद आप वायरली सप्रेस हो जाएंगे और आप अपना हस्बैंड वाइफ ट्रांसमिशन, मदर ट्रांसमिशन नहीं होगी। तो इन टर्म्स ऑफ ट्रीटमेंट हम बहुत करीब पहुंच गए वैक्सीन के। जो एक अभी मैंने वो पूछ टच नहीं किया कि व्हाट इज प्रेप। फिलहाल मैं इसको ये कहूँगा, अगर दो हस्बैंड वाइफ में से किसी एक को HIV है और उन्होंने कंसीव करना है, तो हम दूसरे कपल को जो नेगेटिव है उसे दवाई देते हैं जब तक माँ कंसीव ना कर ले। तो HIV बहुत तेजी से एडवांस कर रहा है। आई थिंक वी आर वेरी नियर टू अ वैक्सीन, बट इट इज अ डिजीज ऑफ लाइफ स्टाइल। तो बीइंग अ मुस्लिम, बीइंग इस्लामिक कंट्री, हमें देखना ये है कि हमारी वैल्यूज क्या हैं। हमारी वैल्यूज ये कि हम बेरारबी को बुरा समझते हैं, तो हमें स्टिक करना है। एक तो हमने इन्फेक्शन प्रिवेंशन को इंश्योर करना है, हमने अपने इंस्ट्रूमेंट्स को, OT को, लेबर रूम को, हर चीज को हमने कोशिश करना है। इट्स नॉट फॉर HIV, फॉर ए हैप्पी एंड हेप्सी ऑल्सो। तो हमें, और ड्रग्स के खिलाफ मैंने अर्ज किया कि ड्रग्स एक बहुत बड़ा सोर्स है दुनिया में HIV का, खासतौर पर पाकिस्तान में। जी।
Sir, I have a
ठीक है।
question.
प्लीज गो अहेड।
Sir, I wanted to ask you what was your most difficult case or moment in dealing with HIV patients, as you have dealt with lots of patients, and what did it teach
First of all, I am a public health person, but I have seen my first case in 1994 in a hospital's ER, and it was very difficult to absorb first of the result of HIV. And other thing, within a week, I in 94, I was working in ICU, and my patient was HIV positive, and the whole staff refused to treat the patient. And they requested hospital management that they will not work in the ICU. So the denial of services. I think इसलिए my first choice is कि डॉक्टर्स को पता हो कि ये छूत की बीमारी नहीं है, बिल्कुल छूत की बीमारी नहीं है ये। और खुदा ना खास्ता अभी मेरे मेरे अभी 10 साल से तो मैं डायरेक्ट प्रोग्राम में हूँ। एक भी प्रिक में किसी को, हम जब उसको एआरवी देते हैं, किसी को भी एचआईवी नहीं हुआ, किसी डॉक्टर को नहीं हुआ, तो जो जो डिफिकल्टी होती है जब टेस्ट का रिजल्ट आता है, उस स्टेज को अगर आप कभी देख ले जहाँ टेस्टिंग हो रही है, स्पेशली जो लोग डीजी खान में हैं, दे हैव एन अपॉर्चुनिटी कि डीजी खान में हाई बर्डन है, कि आप जहाँ टेस्ट का रिजल्ट आए, यू विल सी इट्स वेरी डिफिकल्ट टू फेस द सिचुएशन। एक यंग पेशेंट को, जो यंग मेल या फीमेल है, 20 22 25 साल का, को ये बताना कि आपको एचआईवी है, एंड इट्स अ लाइफ लॉन्ग डिजीज। अभी तक तो ये लाइफ लॉन्ग डिजीज है। तो इसके अंदर बहुत ज़्यादा आपके अंदर एम्पैथी चाहिए। आप देखें कि ये किसी को भी हो सकता है, हम में से किसी को भी ब्लड लग सकता है, हमें हमें नहीं पता कि हमें कहाँ पे कौन सा हेल्थ केयर मिले। और पाकिस्तान के हेल्थ सिस्टम में भी बहुत सारे गैप्स हैं, बहुत सारी स्क्रीनिंग की जगहों पे प्राइवेट ब्लड बैंक्स हैं, वी डोंट नो। तो जब तक हमारे अंदर वो इंसानियत नहीं होगी, इट्स के लोगों के लिए एम्पैथी, वी कैन नॉट ट्रीट द डिजीज। जी बेटा।
अस्सलाम वालेकुम सर, मेरा एक क्वेश्चन था कि जो पेशेंट्स हैं, हम उनको प्री एक्सपोजर और पोस्ट एक्सपोजर प्रोफिलैक्टिव केयर कहाँ से हम रिसोर्सेज दिलवा सकते हैं? वे शुड वी रेफर आवर पेशेंट्स को ये
जी
यहाँ से
जी, मैं
आपको
ये लिस्ट आपकी एडमिन दे देगी। हमारे पास फिलहाल 95 सेंटर्स अक्रॉस पाकिस्तान है, मैंने ऐड्स किया, और आपके पास वो लिस्ट होनी चाहिए। और जिसको आपको अपने नियरेस्ट जो एच आई वी क्लिनिक है, उसका फ़ोन नंबर भी मैं दे दूंगा आपके एडमिन को। सो यू कैन हैव, इस वक्त पाकिस्तान में 95 है, मैंने बताया पंजाब के तमाम DHQs में है, और सिंध में भी ऑलमोस्ट, और केपी में 13, और बलूचिस्तान में 7, और फिर GBAJK में है। सो वी हैव अ वेरी एक्सटेंसिव नेटवर्क अक्रॉस पाकिस्तान। और यहाँ पर तमाम जगहों पर ये हमने इंश्योर किया हुआ है कि विद इन 72 आवर्स किसी को एक्सपोज वो पहुंच जाए इंशाल्लाह। तो 72 आवर्स काफ़ी होते हैं, क्योंकि कवरेज अक्रॉस पाकिस्तान हमारा मौजूद है। वो लिस्ट आपसे शेयर कर लेंगे वो आपके एडमिन।
सर, क्या पाकिस्तान में प्री एक्सपोजर प्रोफिलैक्सिस मौजूद है? प्रेप, इज इट
जी बिल्कुल
सफिशिएंटली अवेलेबल?
बिल्कुल बिल्कुल मौजूद है। इट इज सफिशिएंटली अवेलेबल। इशू इज कि अगर मुझे चॉइस दें आप कि मैं पेशेंट को ट्रीट करूं या वो जो हाई रिस्क पे हैं, तो मैं पहले पेशेंट को ट्रीट करूंगा। चूंकि दवाइयां पाकिस्तान में नहीं बनती, बाहर से आती हैं, तो फर्स्ट चॉइस वो लोग हैं जिनको एचआईवी हो गया हो। लेकिन जिनको एचआईवी नहीं है, उनमें भी प्रेप हाई रिस्क लोग अपने अपने सेटअप्स में ले रहे हैं। इट इज ऑफर्ड थ्रू ART सेंटर्स।
ओके, थैंक यू सर,
और
बहुत
अल्हम्दुलिल्लाह,
शुक्रिया।
सॉरी, 10 साल में प्रोग्राम में अल्हम्दुलिल्लाह कोई आज तक स्टॉक आउट नहीं हुआ हुआ। इट्स लाइफ लॉन्ग मेडिसिन। और अल्हम्दुलिल्लाह इस प्रोग्राम में, इसलिए नहीं कि मैं बैठा हूँ, प्रोग्राम इन टर्म्स ऑफ ट्रीटमेंट इज डूइंग क्वाइट गुड। इट्स द ओनली प्रोग्राम जहाँ हमने आउटसोर्स किया हुआ है। आगा खान को हमारा वायरल आउट कर रहा है अभी, तो विच इज़ वेरी एक्सपेंसिव। गवर्नमेंट इसको सपोर्ट कर रही है। लाइफ लॉन्ग मेडिसिन फ्री, लाइफ लॉन्ग, साल में 2 दफ़ा PCR थ्रू आगा खान फ्री, विच कॉस्ट 30,000 फॉर अ पेशेंट, जो फ्री ऑफ कॉस्ट हो रहा है। इफ देयर आर नो क्वेश्चंस, चैट बॉक्स आप लोग देख लें। आप, मैं कॉन्टेक्ट लिस्ट में ये जो रिसोर्सेज हैं ये भी शेयर कर लूंगा। और
Sir, there is a question in the chat box.
जी प्लीज प्लीज बताइए, व्हाट्स
Sir, they're asking how can public health campaigns be restructured to actually reach and influence the high-risk groups like sex workers and drug users? How can we target them?
जी, इसमें दीज पॉपुलेशंस आर वेरी क्लोज पॉपुलेशन। अगर आप किसी ट्रांसजेंडर के पास जाएं, तो ट्रांसजेंडर के पास वो आपकी बात सुनेगा नहीं। तो उसके लिए हम व्हाट वी आर डूइंग एट द नेशनल लेवल, हम ट्रांसजेंडर्स की जो उनकी अपनी तंजीमें, उनकी कम्युनिटी बेस्ड ऑर्गेनाइजेशंस हैं, इसी तरह फीमेल सेक्स वर्कर्स की, इस तरह मेल सेक्स की, उनको हम ट्रेन करते हैं, उनको टेस्ट किट देते हैं और उनको कहते हैं कि आप अवेयरनेस भी करें। उनके गुरु होते हैं एंड दे हैव हॉट स्पॉट्स, तो वो अवेयरनेस भी करते हैं। उनको हमने अपने साथ लिंक भी किया हुआ है और हर 6 महीने बाद उनका टेस्ट होता है, और उनमें से जो लोग पॉजिटिव होते हैं उनको फिर हम ट्रीटमेंट अपनी स्टार्ट कर देते हैं। बट इट्स वेरी डिफिकल्ट टू स्टार्ट सच कैंपेन एट नेशनल लेवल। वी नीड टू रीच देम एंड दे आर हिडन पॉपुलेशन। खास तौर पे ये जो सेक्स वर्कर्स हैं, ट्रांसजेंडर्स आर अवेलेबल, आईडीयूज आर अवेलेबल, ये दोनों आसान है, इजी टू रीच। बट मेल और फीमेल सेक्स वर्कर्स आर वेरी डिफिकल्ट टू रीच। फिर लीगल इम्प्लीकेशंस भी हैं, माशरा भी है, तो बहरहाल उन तक के लिए हमने रास्ते निकाले हुए हैं। वी हैव वेरी स्ट्रॉन्ग कोऑर्डिनेशन विद देम।
So one last question there is, what is the most under-researched areas in HIV medicine that young researchers should explore?
आई थिंक इस द इमर्जिंग चैलेंज जो इस वक्त आ रहा है वो है आईवी लॉन्ग एक्टिंग ड्रग एआरवीज। इस वक्त सारी जिंदगी दवाई खाना इट्स इज अ वेरी वेरी डिफिकल्ट। हम लोग मिजाजन, अगर हमें कोई डॉक्टर 10 दिन की एंटीबायोटिक लिख के दे, हम 7 दिन में छोड़ देते हैं। अगर 7 दिन में लिखे तो 5 दिन में छोड़ देते हैं, बल्कि पहली डोज में जब ठीक हो जाए हम छोड़ देते हैं। टीबी में यही है। तो एचआईवी की दवाई सारी जिंदगी खाना बहुत मुश्किल है, उसमें लॉस टू फॉलो बड़ा ह्यूज है। तो आई थिंक लॉस टू फॉलो को मिनिमाइज करने के लिए अभी ग्लोबली काम हो रहा है, और पाकिस्तान में भी वी वांट टू इंट्रोड्यूस लॉन्ग एक्टिंग इंजेक्टेबल, कि 6 महीने बाद एक डोज लग जाए उसको, स्लो स्लो रिलीज की। तो इस पे काम करने की जरूरत है। और लॉस टू फॉलो दूसरा मैं चाहूंगा कि अगर आप में से कोई काम करें इन टर्म्स ऑफ पब्लिक हेल्थ, कि लॉस टू फॉलो को रीलिंक करने के लिए क्या किया जाए। बिकॉज आई बिलीव इन डिजिटल सॉल्यूशंस। हमने कोविड में जो काम किया है वो थ्रू डिजिटल्स पे किया हुआ है। तो सबके पास पाकिस्तान में मोबाइल फोन है। आई थिंक वी कैन यूज ये 2 एरियाज जो हैं जहाँ मैं चाहूंगा आप लोग काम करें। इस चैट बॉक्स में नया सवाल।
Assalamu alaikum.
जी प्लीज।
I have a
अस्सलाम वालेकुम।
question. I'm Dr. Saima from Rawalpindi Medical University. मैंने ये पूछना था कि आप प्राइवेट में भी काम करें, पब्लिक हॉस्पिटल्स में, जैसे हमारे पास 3 हॉस्पिटल्स हैं पिंडी में, रावलपिंडी मेडिकल यूनिवर्सिटी में, क्या वहां पे भी आप लोगों का इतना ही काम हो रहा है जैसे आप सिंध में कर रहे हैं, डीजी खान में कर रहे हैं? हमारे 3 हॉस्पिटल्स हैं, हमारे पास इतने पेशेंट्स आते हैं, एक्सपोजर भी होते हैं। क्या यहाँ पे इतनी अवेयरनेस डेवलप हो रही है? यहाँ पे काम हो रहा है? यहाँ पे प्रॉपर एआरटी की फैसिलिटीज हैं? मैं सिर्फ
जी
पिंडी की अभी बात कर रही हूँ।
जी बेनजीर भुट्टो हॉस्पिटल के अंदर क्लिनिक है और वहाँ पर ये अवेलेबल है। दिस प्रोग्राम इज अंडर पंजाब एड्स कंट्रोल प्रोग्राम। आफ्टर 18 अमेंडमेंट हेल्थ इज अ डिवॉल्व सब्जेक्ट। सो फेडरल गवर्नमेंट की जो जो जुरिस्डिक्शन है वो सिर्फ इस्लामाबाद है, या हम सपोर्ट करते हैं जीबीएजेके को। बाकी सारा पाकिस्तान, चारों सूबों के पास अपना बजट है, दे हैव देयर ओन प्लान्स। लाइक पंजाब में तमाम डीएचयूज के अंदर अवेलेबल है, और ऑलमोस्ट तमाम टीचिंग हॉस्पिटल्स में। तो रावलपिंडी मेडिकल यूनिवर्सिटी का जो बेनजीर भुट्टो हॉस्पिटल है वहाँ पर क्लिनिक अवेलेबल है। बट आई थिंक यू कैन एक्सपैंड द सर्विस टू डीएचक्यू एंड होली फैमिली, एंड यू कैन टॉक टू योर वीसी एंड आई कैन लिंक इट टू योर जो पंजाब इट्स कंट्रोल प्रोग्राम। थैंक यू।
थैंक यू।
Sir, there's one more question.
जी प्लीज।
Sir, they are asking if Pakistan is an Islamic country, so how can we identify such high-risk groups of people and address them?
ये बहुत अच्छा सवाल है। आई थिंक देखिए वी नीड टू अंडरस्टैंड दो बोथ पर्सपेक्टिव। वन, मैं पहले इंसान हूँ, फिर मुसलमान हूँ, फिर पाकिस्तानी हूँ। दीज पॉपुलेशंस are everywhere in the world, and but they are invisible. See, so what we work, how we work with them, we locate their activists. There are certain transgenders in activists. So इसी तरह नई drugs में there are certain NGOs who are activists. इसी तरह ये जो आप मेल और फीमेल सेक्स वर्कर्स के there are few activists. So we work through, and that's why the name is community based organization. So हम डायरेक्टली गवर्नमेंट नहीं, गवर्नमेंट का काम आउटरीच में बहुत चैलेंजिंग होगा, और फिर लेजिस्लेशन के भी इश्यूज हैं। इसलिए पाकिस्तान में नशा इस्तेमाल करने पे भी पाबंदी है, बेचने पे भी पाबंदी है, तो उनके द्वारा काम करना बहुत चैलेंजिंग है। तो वो लोग जो इसके अंदर हैं, वी इन्वॉल्व देम, वी आस्क देम टू कम फॉर मीटिंग एंड वी वर्क थ्रू CBOs, कम्युनिटी बेस्ड ऑर्गेनाइजेशन। सो ट्रांसजेंडर्स के अंदर ट्रांसजेंडर्स काम करेंगे, मेल और फीमेल सेक्स वर्कर्स के जो उनके हॉटस्पॉट्स के अंदर वो लोग खुद काम करेंगे। वी गिव देम ट्रेनिंग फॉर टेस्टिंग एंड वी गिव देम द लिंकेज when somebody is positive, where to go. But again, it's in a country like Pakistan, but we have, Malaysia, we have Bangladesh, we have Afghanistan. So this is a public health issue. We need to identify ways, हमें रास्ते निकालने हैं उन लोगों तक पहुंचने के लिए, बिकॉज अगर हमने उनको कंट्रोल ना किया तो वो पूरी की पूरी जनरल पॉपुलेशन में HIV आ जाएगी, एंड इट्स वेरी एक्सपेंसिव डिजीज, लाइफ लॉन्ग मेडिसिन, लाइफ लॉन्ग PCR. सो वी नीड टू, और पाकिस्तान के पास अभी तक टाइम है, आई थिंक वी हैव 3-4 years जिसमें हम इस एपिडेमिक को रिवर्ट कर सकते हैं.
Sir, I think if anyone has any question, please unmute your mic or drop it in the chat box. Sir, there's one more question.
Please.
Sir, they are asking you what are the challenges for in a low-income country for ART adherence therapy? Like, is there any problem in the adherence of ART therapy you have discovered?
It is not the adherence only. First of all, the procurement. Because पाकिस्तान के अंदर एक्टिव ड्रग हमारे पास ARVs पे कोई 53,000 पेशेंट्स हैं. सो WHO प्री क्वालिफाइड पे कोई मेडिसिन कंपनी अभी तक पाकिस्तान में दवाई बना नहीं रही. 90% दवाइयाँ इंडिया से आ रही है. इट्स अ वेरी डिफिकल्ट सिचुएशन. हमें दवाइयों को पाकिस्तान में लाना एक चैलेंज है, और फिर लाइफ लॉन्ग उसकी सप्लाई लाइन को के, लाइक कोविड में सप्लाई ब्रेक हो गई थी. इसी तरह PCR की कॉस्ट 30,000 रुपए है. सो साल में 2 दफा PCR कराना होता है. सो इट्स अ वेरी एक्सपेंसिव डिजीज. इट्स फॉर लो रिसोर्स कंट्री HIV अगर खुदा न खास्ता हमारे यहाँ आ गया तो हमारे हेल्थ सिस्टम पे अभी तक डायरिया और ARI ट्रीट नहीं कर पाए हैं, हम क्रिपल हो जाएंगे. सो द शॉर्टेस्ट रूट इज prevention, prevention, and prevention. And I am not ashamed. As a Muslim, we need to practice Islamic lifestyle. जो भी अल्लाह मियाँ ने कहा है, that is, उसमें ही हमारी भलाई है. हेल्दी अल्लाह मियाँ ने यही तो, ड्रग्स अवॉइड जो है बेरारवी. तो वी नीड टू अंडरस्टैंड दिस एंड स्ट्रॉन्ग IPC प्रैक्टिस फॉर डॉक्टर्स एंड मेडिकल स्टूडेंट्स. माय एडवाइस इज, हॉस्पिटल के अंदर जाने से पहले आपकी जेब में ग्लव्स और मास्क हों. स्ट्रॉन्ग ट्रीट एवरी पेशेंट है कि उसे हेप सी HIV है. आप इसका इंतजार ना करें कि कोई प्रिक हो और आप भागें. एंड बिफोर गोइंग टू हॉस्पिटल यू मस्ट बी वैक्सीनेटेड फॉर हेपेटाइटिस B ऑल्सो. जी.
Sir, I think that's all. Thank you so much, sir. Your efforts are commendable in the field of HIV and AIDS, and that was a very thoughtful and thought-provoking session for all of us. Thank you so much for your time.
Thank you.